I'm Jeanette Benigas, the owner of Fix SLP, and welcome to Fixing the Coding Chaos series. This is video number 5. Before we jump into it, please hit subscribe. We are trying to meet clinicians who aren't on social media, and right now this is one of the best ways to reach them. The larger the following, the more people will find us. Let's get into documentation, prescriptions, and authorization. When I went through the list of questions people have asked, I really liked some of these practical concerns from clinicians right now, like what happens to physician orders, documentation, plans of care, and prior authorizations when therapy codes become more segmented. I think this is where people have stopped thinking abstractly about CPT code structure and have started to realize how these changes could affect their day-to-day clinical workflow. I was asked a few times, will physician prescriptions need to specify articulation, language, fluency, cognition, voice, and all these separate treatments individually? And the honest answer is, we don't fully know yet how individual payers and systems will operationalize like this. But we do know that healthcare systems often follow the structure of the codes themselves. Historically, broad treatment codes have allowed for broader physician orders. For example, my favorite, ST to evaluate and treat, often worked because the treatment code of 92507 is broad and integrated. But when codes become more segmented and descriptor specific, healthcare systems sometimes start expecting more specificity upstream as well, which leads me directly into the next question. Will eval and treat orders still work? Possibly in some, possibly not in others. That remains to be seen. Some facilities may continue to allow generalized orders under standing protocols or broader therapy authorizations. Others might tighten compliance requirements and begin requesting more diagnosis specificity, more treatment specificity, and more explicit physician intent tied to the individual treatment domains. And this is important. Sometimes those requirements don't come directly from the CPT process itself. That comes from payer interpretation, utilization review, compliance departments, EMR workflows, or authorization vendors trying to operationalize the new structure. Clinicians often think, well, the CPT code didn't explicitly say that. But downstream systems frequently build their own rules around the code structure, and they're always looking for reasons not to pay. Let's talk about documentation and how that plays a role in the new structure. How specific will documentation need to be? Likely way more specific than what many clinicians are used to when separate categories exist for treatments like fluency, articulation, language, cognition, voice, combined services. Then documentation may need to justify which domain was treated, how much time was allocated, why codes were selected, and whether an add-on service was appropriate. And that could create major workflow implications for clinicians who naturally treat communication in an integrated way. Because real patients don't always present in neat little boxes. A pediatric session could involve language, speech sound production, social communication, AAC, executive functioning, and or throughout include caregiver education, all within the same 30 minutes, the same 45 minutes, or the same hour. An adult neuro session could involve cognition, aphasia, dysarthria, swallowing-related communication training, memory strategies, and caregiver coaching, all fluidly integrated together. So when treatment shifts dynamically within a session, clinicians are asking, how exactly are we supposed to document under these narrower categories? And that concern becomes even more complicated when we start talking about plans of care and prior authorizations. Because another major question is, how will plans of care and prior authorizations work if treatment focus changes weekly? Legitimate concern. Speech-language pathology treatment is often responsive and evolving. A clinician may focus heavily on expressive language one week, cognition the next week, AAC training after that, and caregiver training all throughout the process. But authorization systems often prefer predictability and fixed categories. Remember, they're trying to find a way not to pay us. So when the coding structure becomes more segmented, clinics may eventually need more frequent authorization updates, revised plans of care more frequently, more modification of goals, or additional documentation explaining why treatment emphasis shifted. Again, this isn't necessarily because clinicians are doing anything wrong, but because systems built around rigid categories often struggle with fluid clinical care. And that's where clinicians are worried because administrative burden could increase dramatically. And how's that going to fit into our already concerning productivity standards? That leads us to a final question that I've seen in my list is how detailed will treatment notes need to become? And honestly, this may end up being one of the biggest operational changes of all. Notes may need to become increasingly granular in order to support code selection, justify timed increments, distinguish treatment domains, defend medical necessity, and reduce denial risk, which could mean more breakdowns of time, more explicit rationale, more category labeling, more detailed goal mapping, and specificity about what exactly occurred during treatment, because they don't want to pay us. Some systems might adapt smoothly, but others may create documentation expectations that significantly increase clinician workload. This is why we need to be talking about this and having the conversation now. It's about workflow, it's about administrative burden, and it's about how integrated therapy gets represented in systems that are now going to prefer fragmentation. And ultimately, this is about if the structure of speech-language pathology documentation will reflect the reality of how clinicians treat patients. I hope this is helpful. If you have more questions, please ask them in the comments below. Hit subscribe while you're there, and we'll see you in the next one. Bye.